Welcome to the Heart of It, where we take our listeners to the heart of healthcare. I'm your host, Dr. Victoria Lee. Thank you so much for joining us today. As we begin today's podcast, I'd like to acknowledge that I'm recording from the traditional, ancestral, and unceded shared territories of the Coast Salish people, and in particular Musqueam, Squamish, Tsleil-Waututh First Nations, and home to Vancouver Sea to Sky Métis Association. Absolutely thrilled to have Helen Bevan with us today, who's one of the leading voices when it comes to innovation, transformation in healthcare. And she's currently professor of practice in health and care improvement at Warwick Business School and strategic advisor to the National Health Service Horizons team. She's had a long history with Fraser Health, actually, and she's only in Vancouver for 2 days for the Quality Forum for 2024. And I know her schedule's very full today, so very much looking forward to spending a few minutes with her today. Some of the audience might not be as familiar with what is actually quality improvement and how do you define quality improvement in healthcare?
So even the term quality improvement, Victoria, is interesting because there's a big shift going on. Certainly in my country, in England, people are talking less about quality improvement and more about continuous improvement. So less QI and more CI. So let's talk about both. So like quality improvement is about making sure that the services that we offer are accessible, safe, equitable, person-centered, and if you like, it's a systematic approach to enabling that. Again, as part of the kind of the movement that we see happening, very often quality improvement is about specifying a quality standard, that we want services to achieve, and how can we incrementally improve every service to hit that quality standard. And again, this big shift that we see going on, again, certainly in the UK, is towards continuous improvement, which is about how do we work across not just on specific quality projects or quality standards, but how do we make our whole organisation or our whole system one that continuously improves. So we have a lot more focus on aspects like leadership capability for improvement, how we build capability for improvement across the whole system, how we put support systems in place for continuous improvement, and how, like as an organisation or a system, we're learning all the time. So in a sense, continuous improvement, how I would define it, is like quality improvement on a bigger scale. Yeah, tied to being a learning organization. And I mean, the other aspect I'd say is that very often quality improvement is done, there's like a quality improvement department who are a group of people who are like the full-time quality team who troubleshoot and go around the organization and help people to do quality projects. Whereas when we're talking about continuous improvement, it's not like a peripheral activity for a group of enthusiasts, okay? Yeah. It's something that everybody should be doing. Improvement is part of everybody's job. The whole kind of the mantra of it is like everybody has two jobs. We have a job which is to deliver our clinical work or our leadership work or whatever our core job is, and our job is to continually improve the work that we do and the service as well.
And in that kind of dual role, how do you find that people find success or organizations find success in enabling, empowering that, especially as we're currently dealing with the human health resource crisis really globally?
Yeah. And I think there's tensions that have to be held. Okay, in doing this, Victoria, because on the one hand, like everybody should be being supported to do improvement, to be doing their own small scale experiments, improving their own services. So it's improvement is something that we should be doing at the point of care, at the heart of the relationship between the person that uses the services and the people that provide the service. So it's a very kind of individual, unique thing for everybody. And in order to enable that, it's got to be about the senior leaders and the board of the organisation, like really investing in continuous improvement as an approach. So, when we think about the biggest priorities, of our organisation, those are the areas that we should be putting our continuous improvement focus on. So, and I think, and again, research shows us this so strongly. Just the role that senior leaders, should be playing in terms of lighting the path, showing the way to everybody in the whole organisation when it comes to continuous improvement. And I think particularly for people that work and support healthcare improvement, I think things are really changing, and they're changing in a lot of countries, because I think we have at least a 30-year tradition now of using quality improvement approaches in our health and care systems, but it's shifting, and it has to shift, because to date, I think things have been very, small-scale incremental change. Doing plan, do, study, act cycles, in a sense, working with an existing system and taking out the unwarranted variation, or improving the flow of services, or making it easier for people, or navigating things for people to go through the system, and those things remain important, but they're not enough anymore. We need to be looking, I think, at the same time for more radical solutions. Different ways of doing things. And one of the things that I see happening across the world is we need bigger change, and we need to take all that learning and capability from incremental improvement, and we need to do things on a bigger scale.
What are some of the global best practices that you're seeing, and specific solutions that give you hope, given that context that we talked about, that are really disruptive, creative, and transformative?
Yeah. So I think some of the most interesting work that is going on in quality improvement is the focus to much more relational approaches. So again, if we think about the last like 10 or 20 years, a lot of the focus around healthcare organisations has been around like an enterprise-wide or a whole organisation-wide approach to quality improvement. So, how are we improving our pathways of care? How are we taking out the unwarranted variation? How we're making it easier for our service users to use our service across the whole organisation, and a lot of that is really impressive. And what we're starting to see now, I think, is a shift towards a different kind of focus, which is about improvement that happens as close to home as possible for people. Different relationships between people that use services, their family. A word that's getting used a lot that I haven't heard for a long time is kin. People talking about the role of kin in health and care. So beyond someone's immediate family, but the kind of social environment that they operate in, and then team-based working, in environments close to people's home, so that the person has a relationship with a core team who might or might not include a doctor, and the whole team being geared up around that person, but really different kinds of relationships. And then I'd also say that some of the technological innovations that we're seeing are being geared up to really support that. And again, with the development of artificial intelligence and machine learning, and some of the situations where, in a sense, we talk about keyboard liberation. So instead of a clinician behind a desk, typing away, actually, a situation where it's an actual conversation with nobody typing anything, and the prescription gets done, the notes get done. So enabling clinicians and people that use services to just have a different kind of dialogue. So much more person-centered. And then another thing I'm seeing, I really see it here, I see it in Australia, seeing it in New Zealand, is such a strong embracing of an Indigenous worldview, and the way that is impacting on the system. So again, when I think about, I did some work in New Zealand, and it's just kind of wonderful to see that in terms of like Te Ao Māori, which is a Maori, a Maori worldview, and you look at so many components of that, which is, look at the whole system, don't look at silos. Learning is like real, it's active, it isn't didactic. Everything is about interconnectedness.
Yes, much more holistic, connected, integrated, generational, and wellness focused, not
absolutely.
Sickness focused.
And I think some of the the opportunities or the inspiration, like for everybody, to create the kind of next generation of health and care services that are actually built on a different worldview. And again, one of the things that I see that's really positive since the pandemic has been the growth in the compassionate leadership movement.
Absolutely.
And understanding that, and we need to bring that to thinking about productivity. So it's very, very hard when to say, we've got to make the space for learning and inquiry in a system that often we need every single person to be working every hour of the day just to keep our patients safe and just to give people access. And I get that, but I think it's our job as leaders, to create the space for people to put their heads up, to learn from each other, to share, and I think, we see this time and time again, that when that happens, it creates a sense of possibility and energy and hope and encouragement of doing things differently. And it's part of our job, as leaders, to kind of manage the tension between everybody, all noses to the grindstone, because we've just got to deliver versus creating a different tomorrow.
Yeah.
And it's why it makes leadership jobs, I think, so tough.
But also a huge privilege at the same time. And I think sometimes we kind of make it as like too big when you're in that scarcity mode. It's easier to make it as it's a huge job, but we know also from compassion evidence that and data actually only takes 30 seconds to establish that with patients. And in terms of like the actual work that we're talking about, it doesn't have to be as onerous, but I think that's, again, creating that space and talking about that too. And I wonder about, related to that is risk-taking. Because I think when you're in that scarcity mindset, it's more difficult to take risks. And we're already in large organizations. People are trained to be risk averse in terms of clinical training, but we do need that massive kind of change disruption. So I found in some cases that relational kind of work and risk-taking, there's ample examples in resource constraint settings. I'm curious about what you've found globally.
So I think it's a complex situation. But I also think that I think one of the really big issues here is around psychological safety, and about how we make it safe to try new things, to encourage ideas, and support each other to make change. And the reality is that in terms of it's like really profound stuff, really, like human capability and our ability to do our very, very best work at work depends on us having feeling a sense of courage and the ability to try some new things. And again, one of the books that's inspired me recently is the new book from Amy Edmondson from Harvard, and she talks about intelligent failure. And what she talks about there is intelligent failure is different to other kinds of failure, which is about like error. Okay, so simple failure or complex failure, which are patient safety issues and error issues. Intelligent failure is in situations where we want to try some new things and we don't quite know what the answer is going to be, but we need to try it out in a small way. And I think again, if as organisations, we can build systems for intelligent failure, trying out new things in small scale ways and supporting each other and building the sense of psychological safety to enable that. I think it's a really powerful way forward.
You have some brilliant examples that we talked about that we've been able to benefit of, Fraser, from Change Day to Engagement Radicals, right?
Yeah, I was so happy to see some of the ERADs, the Engagement Radicals, on the virtual session that we did earlier, and they were people that colleagues from Fraser Health that I met here when I did a workshop with the ERADs in 2015, and I tell you, some of those people are just as enthusiastic and passionate, and I congratulate you, with the continuity that's after 9 years is still happening.
Oh, thank you. And thank you for, I think, seeding that, I think, very practical, pragmatic. And sometimes it doesn't take a lot, right, to have those very enthusiastic and powerful change agents in the system.
Exactly. And it's relational because in a sense, it's about people in the system that want to make change happen, coming together in community and supporting each other to do some brave but supported things, and getting support from the organisation to do that.
As you were chatting, I was just thinking maybe version 2 of Engagement Radicals should be the broader relation in our communities.
Wouldn't that be amazing?
Right.
Yeah.
So you should come back and we can launch that together.
Yeah, I think that would, because I think, no, I do think, ERAD's, 2.0
yes.
would be fantastic.
Yeah. We'll have to pencil you in for when you're next in town so that we can launch that version 2.0.
Yeah.
And last question I'd love to ask you is, what's the one word that you would use to describe future of healthcare, and why?
The one word that I would use is agency. And agency means feeling the sense of power and permission to do the things that you want to do.
Yeah.
And I think all of us that work in publicly funded health and care systems, like we want to build a sense of agency for everybody that uses our services. We want people to feel agency, like having control of their own health, and also like we want our entire health and care workforce to feel a sense of agency that they can be improvers alongside their their day-to-day jobs, and I think having a social movement of people who have got a sense of agency to make a difference in the world. The sense of that makes me feel very hopeful for the future.
Oh, thank you. Agency. I think that's been part of your 30 plus years in career as well, giving people agency as well as giving the whole health system agency. So
or helping people to build their own.
Yes, exactly.
Helping the system to build this agency.
Yeah, beautiful. Well, thank you, Helen. It's been such a privilege to have you share a little bit of your time with us while you're in BC. And I'll also acknowledge our BC Quality Council as well as the forum for sparing a bit of time as well as this space. Thank you so much.
Okay, it's been a pleasure.
Join us next time as we continue to get the heart of healthcare. And please don't forget to subscribe and rate this podcast. The Heart of It is a Fraser Health production. I'm Dr. Victoria Lee, your host. Recording and editing is done by Fraser Health Communications and Public Affairs.